Welcome to the Lupus Lifestyle Series panel on family planning and fertility, presented by the Lupus Research Alliance Young Leaders Board. Hi, I'm Sarah Schottenstein from the LRA YLB Leadership Committee, and I'm pleased to be your moderator this evening. We are incredibly excited to welcome two distinguished physicians to our panel who specialize in high-risk pregnancy, Dr. Buyon and Dr. Mehta-Lee. Dr. Buyon is the director of the Division of Rheumatology and the director of the Lupus Center at NYU Langone Medical Center. She's also the co-director of the Colton Center for Autoimmunity. And Dr. Mehta-Lee is the clinical associate professor of the Department of Obstetrics and Gynecology at NYU Grossman School of Medicine. And she's the site director of the Division of Maternal Fetal Medicine at NYU Langone Hospital in Brooklyn. We are also thrilled to welcome Kelley and Mike Baine. Kelley is an active Young Leaders Board member and lupus warrior, and Mike is a loving and supportive husband. They are both proud parents to two young children.
So we did a very large study, actually, myself and Jane Salmon, and she'll be part of it, and all of us, doing a study on the largest prospective study of women who started out being very stable. And, obviously we discussed being in remission prior to pregnancy. And I think, as many of us know, remission is not always defined the same way for every single patient. And some patients will always maintain, for example, antibodies to DNA and even have low complement. And such a patient might say, oh, maybe I can never get pregnant because I'm always in a state of some degree of activity in my bloodstream. And I think that's a big misconception, because there are some people where you do the best you can. And remission in this case might not be the same as remission in a clinical trial and an endpoint in a trial. Here it's, how can we optimize you being the best that you can be? And I think that's a really important point. Can we change your medications that are unsafe? And can we still have you in a relatively stable point? Now, certain factors we have identified do confer a slightly higher risk of more difficult pregnancy outcomes, or what we refer to as adverse pregnancy outcomes. And those are being on blood pressure medications, but that might not be something you can change. So knowing that just helps to anticipate what the pregnancy might look like. It's not saying, oh, if you're on a blood pressure medication, it's contraindicated. Actually being non-white, so being a minority in and of itself, confers a slightly greater risk than if you happen to be of white race. Having low platelets is a factor. Being active in disease at the time you're pregnant, that your disease is really not under the best control. And then lastly, having a lupus anticoagulant. Now, these are 5 factors that put you at greater risk for an adverse pregnancy outcome, but they are not contraindications. And I think that's really an important point.
So when we think about preconception counseling for medications specifically, we're going to talk about what are the safest medications one can use in pregnancy. And of course, some patients are going to need to take different medications than the ones that we're most used to. But we generally recommend that patients are on Plaquenil or hydrochloroquine in pregnancy for their lupus, and that there are some cases in which steroids, generally the fluorinated steroids, are utilized in pregnancy because they don't cross the placenta and cause fetal effects. And then depending on renal state, depending on whether or not there is a need for alternate immune modulating agents, there's a lot of data on the use of azathioprine in pregnancy, and we can use that one. And then, as Dr. Buyon mentioned, many of our lupus patients also have hypertensive disorders of pregnancy or hypertension prior to pregnancy. For hypertension prior to pregnancy, we recommend generally the beta blockers or calcium channel blockers. Those are considered safe in pregnancy. So when I talk about all those drugs, I'm talking about optimizing your medication regimen. There are medications that we sort of really try not to use in pregnancy. And that's because of their teratogenic effect or their fetal effects in early pregnancy generally. So one of the main ones is methotrexate. We really avoid methotrexate in pregnancy. We know that it can cause birth defects. And then there are other additional medications that we may avoid either in the early portions of pregnancy or later in pregnancy. And it's, I think, really important when we talk about this, not to talk about it in generalizations, because we want remission, right? And so there are times when we use immune modulating agents that might have some, that might confer some risk. As long as that risk outweighs the benefit, we're going to probably continue to use it if it's necessary to keep remission going. I guess I should say for fertility, women who are well controlled, who don't have significant hypertension, and who have good renal function, tend to have good early pregnancy success rates. That's a little different if your renal function is not great. There is an increase in the risk for pregnancy loss. And as well as the antiphospholipid syndrome. Patients who have lupus concomitant with the antiphospholipid syndrome have a reduction in fertility due to early pregnancy loss. And that's typically mitigated by the use of heparin and aspirin, though not perfect, can really improve early pregnancy outcomes and increase fertility.
I was going to say one of the very special circumstances, and this would be more known to rheumatologists and lupologists, is the person who's been on a medication that I think you're all very familiar with called MMF or Cellcept. And I think many of us are aware of this medication and aware that that is another medication that we do not prescribe during pregnancy. And so part of it is making some changes. So for example, if somebody were on mycophenolate, you might say, well, then they're probably not stable enough. Well, that's not necessarily true, because in lupus, there are a lot of drugs that we maintain patients on, not just to treat an acute flare, but to maintain remission. This is an interesting point. So if you're doing well and you're on MMF because you had kidney disease 5 years ago that now is under control, it's important, and that's where pre-pregnancy counseling comes in, to say, well, we want to stop this medication, and we're stopping it, for example, 3 months early, not because it takes 3 months for the drug to come out of your system, but rather to make a change to another medication, for example, like Imuran or azathioprine, or not even give you another medication, and to give a month or so to see if, how will you do with this change of medication before you get pregnant? So a lot of the medication planning, as Shilpi said, is very individualized. And I think the other medication that has surfaced as the great news, we've gotten some really fantastic new medications for lupus, for example, belimumab. People are on belimumab, they're doing well on belimumab, and what do we do with a drug like that? And I think it's important, just like in rheumatoid arthritis, we've learned that some of these monoclonal antibodies are actually quite safe in the early parts of pregnancy because they don't even get transported across the placenta. So in some cases, medications will be maintained early and actually stopped as we head into the second trimester or early third trimester. So there's a lot of nuances here. And, we could go through all the specific medications, and I'm sure you can find all these from many resources on the internet or lectures, but I think this is the point of pre-pregnancy counseling, to adjust the medications to be as optimal. And as well as hydroxychloroquine, we all agree aspirin is very important to prevent preeclampsia, which there is an increased risk, even for a stable lupus patient, to develop preeclampsia compared to someone who doesn't have lupus. This is a reality. We discuss it and we deal with it.
We generally talk about complications in two realms. We're going to be doctors for both the mother and the fetus. And so we're going to talk about maternal complications and fetal complications. Maternal complications, probably the biggest one that we think about in women with autoimmune disease, is preeclampsia. Preeclampsia is where your blood pressure goes up towards the end of the pregnancy, typically in the late third trimester, although it can be earlier. We see preeclampsia even as early as 22 to 23 weeks in some of our worst autoimmune disease patients. Preeclampsia, the actual cure for preeclampsia is delivery. So if it happens really preterm, we want to try to avoid that And the best way to avoid that is to give aspirin. So 81 milligrams of low dose aspirin has been shown to reduce the risk of preeclampsia by approximately a third in a high risk patient population. So really, really good drug. It doesn't, I like to tell my patients, it doesn't get rid of your aches and pains. It's not going to thin your blood enough to really change anything in terms of fetal effects, but it does improve placentation. And that is how we think that mechanism works to help that placenta grow and grow well in the uterus. So it's really important to start at around 12 weeks and to continue until you deliver. And then in terms of fetal complications, the main fetal complication also has to do with building a healthy placenta, and that has to do with growth restriction. So it's more common to see issues with fetal growth in any of our patients with autoimmune disease. We monitor them very carefully throughout the pregnancy. We measure the fetus typically every 4 weeks in the third trimester and more frequently as needed. We check their fluid, the fetal fluid, the amniotic fluid around the fetus every week, starting at around 32 to 34 weeks, depending on which institution you work at. So we're really, really checking on fetal well-being, really in the early third, all the way through the delivery. Those are the two main complications. I think everybody would say that in patients on steroids, specifically prednisone or methylprednisolone, there is an increase in the risk also for gestational diabetes, which has a consequence to both mother and fetus. Pregnancy-induced diabetes can cause babies to be bigger than we expect, which is a little bit of the opposite of what I just said with placentation. But also it's pregnancy-induced diabetes is associated with a multitude of other complications. And so if women have it, as Dr. Buyon likes to say, we deal with it. We don't want them to stop their steroids necessarily, but we can help them deal with diet and exercise generally. And if not that, then we can give other medications for their diabetes. So I think those are the real main ones. A lupus flare is another big complication during pregnancy. It's not specific to pregnancy. Women can have flares in pregnancy, outside of pregnancy, in the postpartum state. We've had a couple patients, Jill and I, whose lupus has been diagnosed in pregnancy, whose first flare was in pregnancy, and that's a complication that is probably slightly more complicated to deal with in that diagnostic conundrum. But Jill, do you want to talk about lupus flares?
Well, this is interesting. Just to keep as up to date as possible, and actually Shilpi and I have not discussed it, but there's a lot of issue with cardiovascular complications. And actually at this year's ACR, believe it or not, the plenary session, and this was done through electronic health record, and we can say whatever we want about health records versus actually seeing patients, but it appears to be that there really are increased cardiovascular complications in patients with lupus who are pregnant, and in particular postpartum. And something that has come out that actually Shilpi has taught me is the importance of finding out whether you need in the postpartum period actually a Lovenox and really anticoagulation. And I have been very resistant to that and thinking about it, but this abstract came out and it will be a big splash at the ACR. And obviously preventing a DVT postpartum plays very much into this cardiovascular risk. And I think we need to pay a lot more attention to that risk because it's real and it is avoidable. So I just want to mention that as another kind of pregnancy-associated complication, to remember that that is a very big time of increased clotting risk. But apart from that, really in terms of lupus flares, how do we treat lupus flares in general? In general, don't cover your ears and be upset. But the true answer is glucocorticoids. Prednisone is probably the mainstay of therapy if somebody has a flare during pregnancy, because prednisone in its form as prednisone or even methylprednisolone doesn't cross the placenta. Only the fluorinated steroids do, and they're used for a different thing we'll talk about later. But also, there are medications like tacrolimus, like Imuran. So there are medications that are safe or relatively safe in pregnancy that we can use if a patient has a flare. So having a flare is not the end all and be all. And I think, that's very reassuring that we can manage that. It's not like, oh my God, we can't manage. We have to deliver. Everything is awful. That is absolutely not true.
So, I think this question is not that specific to just lupus patients, right? So, anyone can struggle with fertility. The reasons are many. Some haven't found the proper life partner or someone that they want to carry a pregnancy with or choose to have a pregnancy with. And others really just cannot get pregnant. So there's such a huge gamut of what infertility means to us these days. And there is an equivalently large menu of how one can get pregnant, right? And so let's start at the very beginning. If a patient is struggling to conceive themselves, but if they are biologically female patients, they should initially see their gynecologist. They should track their cycles. They should use the apps to see how often they're having cycles. And nowadays, you can even get over-the-counter ovulation predictor kits. So, the very most basic stuff, a lot of patients are doing on their own. They're tracking their cycles. They know when they ovulate. They show up at their gynecologist, and they would say, hey, I've been trying for X amount of months. I don't know if I can get pregnant. The typical diagnosis of infertility is a year without conception, but we don't really recommend that all of our patients wait a full year before seeking care. And so it's really, really important to touch base with your gynecologist earlier than that. And this is really important in our autoimmune disease patients and our lupus patients, because if you seek care early and get that preconception counseling, you can even get ahead on some of this fertility counseling. When you're looking to start a family and you're struggling, the best resource is really always the infertility specialist. So I'm a maternal fetal medicine specialist, but the next step is going to be our reproductive endocrinology colleagues. They're going to do blood work. They're going to do imaging to help them decide where it is in the process that people are struggling to conceive. And they also take care of our male patients as well. They look at sperm count and semen analysis to make sure the semen quality is good, the sperm quality is good. And so that's a really important part of the process. If you can't carry a child or you don't want to carry a child, there are gestational carriers available through the fertility centers. And now gestational carriers are allowed in the state of New York. That's a new thing in the last couple of years. Before that, we used to have to send our patients to Connecticut and New Jersey. We're based in New York City. But in Connecticut and New Jersey, we were allowed to have gestational carriers. But now New York State offers gestational carriers. You can also do, if you don't have don't have embryos or eggs, you can do embryo adoption, you can do egg adoption, you can do sperm donors. It's really quite a menu in terms of who can get pregnant and how. And then, of course, there are also adoption resources that we point some of our patients to who don't want to go through any of this. And I just the caveat here is that, if people are struggling to get pregnant, we really have to meet them where they're at in terms of where their next steps are going to be and what they want to do. And sometimes, if patients have a history of pulmonary embolism or venous thromboembolic events, these are questions we have to answer in terms of what are risks and future risks when we conceive. So there's a lot.
I would say, the goal a lot of the time is to kind of prevent any lupus flares and lupus feelings that I get, kind of the inflammation around my pericardium, my heart sac, and in my legs and in my hands. And, the way I do that is try to low stress. Even though I have 2 kids, it's a little hard, but I feel like I've switched my job over from, a demanding startup where I worked many, many, many hours to a more flexible job. So, as a real estate agent, so obviously that can still be very demanding, especially as I grow my business. But for right now, I have a team that can support me. There's technology that can make my workflow a little easier. Down the road, assistance and things like that. So I feel like I'm set up right now to kind of be an independent contractor and have a little more flexibility in my life, which is, what I wanted during my childbearing years. And then, listen to my body. So I know that the sun affects me and, the healthier I eat, even though it's hard sometimes, like the better I feel. So kind of knowing what I need to be doing, saying no to things sometimes, just because I know I have this much energy, and if I'm starting to fade, I don't want that to be kind of what people see me as. And so I'll just retreat, having, such a supportive partner who does kind of everything, and taking turns is really important. So although we both want to parent both our kids all the time, just taking turns has been very helpful for us,
I would say, you be as positive and as supportive as you can. Have a lot of patience, and know that there may be bumps in the road. Try to be the force in the relationship that maintains, the calm and the stability and the daily routine that you're used to. I think all pregnant women obviously need support. If anything, I think a partner of someone with lupus is almost better prepared to support that, because in some way, even prior to pregnancy, that's kind of how I think of, my support for Kelley is that, she's strong, obviously, but delicate. And, so I think in some ways it's kind of, I felt a little bit more prepared than, someone else might. And I think, like Kelley said, learn to say no to social events. Don't be worried about excuses. Do whatever, you feel like you can do at the time. And live obviously the way that you feel is best for you in the moment. And then I guess, I would say in the end, as long as your doctor agrees, I really encourage everyone to try, because it's been such a blessing for us. It's a little bit of an unknown. Obviously, every body is different. I would say, we tried to stick to the facts out there and the information from your doctor. I think it's easy to focus on, the negatives and the hypotheticals of what if this doesn't happen for us? What if our kids aren't, spaced, apart the way that we envisioned our family to be? We're both one of 4 kids that were all very close, and like we're still close to this day. So I think, we actually got very lucky with our first kid that, kind of happened naturally and quickly. And then the second one, that was where we really encountered, a lot of the barriers and hiccups that people can encounter. And, it wasn't happening naturally. We did the IUI route and then the IVF route. And I think we, looking back on it, it was such a stressful period in our relationship. And, it's so easy to focus on, the month to month despair that may occur. But I think looking back on it, if we probably would give it the advice of just, trust the process, focus on the long-term goal. And when there are points of despair, don't minimize it. It's like, it's totally okay for you both to be very sad and devastated, but then try to, consciously reset and again, focus on the positives and the future goal. So.
the LRA has been super helpful, just, getting to know some of the young leaders, and getting to, talk about important topics like this, and having this, come to fruition is amazing. So, that everything that I've learned from there, doctors are amazing. And when you go through a pregnancy, you have your rheumatologist talking to your OB, talking to your high risk OB. So you have 3 people on your case, and you feel so supported. And we're going to a lot of doctor's appointments, but I think if you look at it just positively, like, you are getting so many eyes and so many different opinions, you're getting the best care. So I feel like that's really important. And that's where I've been able to kind of release, all my questions. And then there's also, friends of friends who know people with lupus. So just kind of getting to know other people and doing some research, if healthy eating is great for you, going down that road. If you're, you want to try acupuncture or different types of, holistic health initiatives. I feel like anyone can pivot any which way to see what makes them feel good. But in terms of, those are the resources. And then obviously, community support from your town, your neighbors, your family. It's endless, I feel.
Yeah,
the outcome. We
outcomes,
have 2 healthy, which is all that matters, baby, happy, healthy babies, and 1 on the way, newly. So that's very exciting.
Congratulations, you are glowing.
But that, my kids are healthy and that I'm feeling healthy, that's everything.
If somebody tells me that their gynecologist or rheumatologist is nervous about hormonal effects, then, my mind immediately goes to venous thromboembolism or antiphospholipid syndrome. If you've had any of those complications, and, when you do any hormonal treatment, whether it's egg retrieval and freezing or IVF or being pregnant, all of those things incur risk. So I think it's very specific, but at the end of the day, this is something that if you really want to do an egg retrieval and it's not contraindicated based on your medical history, there's probably a workaround. Sure, we can be hesitant, but if you're willing to take some risk, I think there is still a possibility that it can happen. And I think it's a really important point. The vast majority of lupus patients are females in their childbearing years, and not all of us are choosing to conceive or be pregnant in those years. And so egg freezing is an extremely important part of fertility. And I think, given health conditions, what they may, like, we have to think about, well, if she went and got pregnant today, would it be riskier to do an egg freezing cycle, or would it be riskier to be pregnant? And that's sort of how I frame the question often, because it's really not my choice whether or not you get pregnant spontaneously generally, but all the other ones I tend to be involved in. And it's not a fair comparison sometimes to the patient.
I would also just add, I have a lot of patients who've gone through IVF, freezing, every permutation you can imagine. And I would say a lot of success in that regard. Because you got to remember that pregnancy is the time when your hormones are 100 times higher than they are when you're not pregnant. So you got to make it through that anyway. But I would also emphasize, exactly as we heard, that people with antiphospholipid syndrome, perhaps even more than just having the antibodies have increased risks, but we try to mitigate those by giving the same anticoagulation approach. So again, I don't think, with very rare exception, and it has more to do with your underlying lupus, your kidney involvement, your brain involvement, your heart involvement. That's what really dictates whether or not it's okay. I shouldn't say okay, whether, or even safe, whether it's appropriate to be pregnant and expectation. But if it's appropriate for you to be pregnant, then it's probably, in my mind, probably okay to go through whatever it takes to get to that place. Because that place, again, is going to have a lot more hormone and other issues that go on for, 9 months than just the IVF. So I have a lot of patients who've done IVF. So bring the concern to your doctor. I don't care how sick you've been, and we've been through a lot. If this is on your mind, regardless of how sick you've been, bring it to the forefront. I mean, I always think it's kind of interesting when someone is in the middle of a terrible flare and their first thought is, will this affect my ability to get pregnant? And I think that's, a very human and important question, right? And though it might seem, wait, why is she talking about that? Right now, we're talking about this terrible lupus flare. But I think it is important because we like to think of the future and how things are going to be. So I think we've kind of covered what you're asking. Never be afraid to talk about pregnancy, no matter where you're at, right? And then you go through the proper counseling. I have seen the sickest of patients have calmed down. This is what lupus is, right? It's an undulating course, which has its good times and its very bad times. But the most important thing about lupus is that a lot of what you go through during flares can be resolved and not leave organ damage. And therefore, wherever you've been before, always think about, if I'm in a different place, which you well may be, it's time to talk about pregnancy. And that's the point about counseling, right? Change your meds occasionally, fix that up. I mean, that's what it's about, right? So medication changes and going into a period where you're no longer flaring, that's a very positive thing. And that's what I think we want to get your flare under control, stabilize, work around the medications, and then we're there, right?
If you were to say, what are my top 3 things? So start your prenatal vitamin, contracept until you know you want to be pregnant and you've spoken to your doctor, right? So I want you to get pregnant. I want you to have the pregnancy that you desire, but I want you to contracept and not get pregnant until you speak to your doctor. And I think prenatal vitamins are a really important part of this because, using folic acid, especially in patients who have, chronic possible nutritional issues or other issues, I think it's really, 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 really important and can't be understated. And you can start that today, even before you get your doctor's appointment. Those vitamins are available over the counter.
I would add to that vitamin D. There's a lot of interesting research on vitamin D.
Yeah, Dr. Buyon, I was going to add, and vitamin D and possibly even calcium if you're, and then of course we've already talked about the preconception stuff you're going to do when you walk into my office, but start your prenatal vitamin, start tracking your cycles, contracept until we get your medications aligned with pregnancy and your flares under control and your high blood pressure under control. Contracept until we figure out any lab work we need to do for antiphospholipid syndrome and Rowan law,
we didn't talk at all about Rowan law antibodies and heart block. That might be for another time. But if you are going to ask about some new developments, I think it's really exciting that we now utilize a home Doppler monitor. So there's a lot of ways we didn't really talk about a woman's involvement in her own pregnancy once there. And there's some really interesting advances in monitoring that can be done by you at your pace in an ambulatory, setting. And I think there are exciting changes that are going to happen, particularly with regard to some autoantibodies you may have and how up to now we've been advising a certain way we surveil and a lot of things that may actually change while we, empower women to really take care of their own pregnancies in cooperation with us. I think you're going to see changes there.
Just to touch on breastfeeding, in terms of breastfeeding, we are going to, again, optimize your medications to make sure they're safe for breastfeeding. But also, patients with autoimmune disease should be encouraged to breastfeed. There's usually no contraindication. The vast majority of medications can be tailored to breastfeeding. Sleep deprivation is an issue. So if that's something that causes you to flare, then you can do a mixed modality, or you can pump and have a support person feed in the middle of the night. But there are ways to encourage breastfeeding in the postpartum period. Certainly caloric intake and continuing your vitamins through the postpartum period is very important. And then in terms of postpartum concerns, depending on what type of lupus you have, what is affecting you, I think patients can have flares. There are shifts in hormones, there are shifts in the drug and drug quantity. And so I think you do have to watch for flares a little bit. You have to watch for blood pressure changes. You have to watch for your platelets in the immediate postpartum period. And then probably the big one that we don't talk about enough is postpartum depression. I think it's extraordinarily common in women with autoimmune disease to have some level of depression. But I think it's so common in the postpartum period, and really close contact with your healthcare providers and your family and your support system is how we're gonna work towards that. If you already have a known diagnosis, then working with a therapist or utilizing medications. SSRIs are extraordinarily safe in breastfeeding and can be used really, and are used ubiquitously as long as there aren't contraindications. I think it's really, really important to consider that as part of your postpartum care. And then, of course, the VTE prophylaxis that we talked about for the vast majority of our patients.
I also want to say something that may be a little controversial, and maybe you'll think less of me, but I've had patients where they have flared, whatever, and it's necessary to change medications that are contraindicated in breastfeeding. And I just want to make the statement that there shouldn't be guilt on the part of the mother. Babies can be just fine without breastfeeding. And I'm not going to get personal about that, but many people in my generation did not breastfeed at all. And I think when it comes down to the woman's health and a change in medications that are really important to maintain your good health, there should be absolutely no guilt and no pressure that you're just as competent a mother and your kid will be probably just as healthy if you don't breastfeed. Because I think sometimes there's an overemphasis on breastfeeding that makes women feel like, wow, I'm less of a mother if I don't breastfeed. I'd like to say that I really discuss this a lot with my patients. And if they're exhausted and they don't want to do it, and maybe there's a medication issue, I try to really support the fact that breastfeeding is not the thing that makes or breaks you as a person or a mother. And I really mean that, particularly with lupus, where there are depressive issues and there's guilt. And I just want to assure all of you that you shouldn't feel that way.
I 100% agree. Fed is best. So no matter how you get fed, fed is best. We always go with that. I just wanted to make sure people didn't think that they couldn't breastfeed, but there are times when medications are contraindicated. So it is, and there are times where you don't want to breastfeed.
Right,
and that's also
exactly.
just okay. So I think Jill and I are on two sides of the coin on this one, but I think we meet in the middle in terms of we want to do what's best for our patients. Hyperemesis, of course. I mean, I've seen it in all of my patients, whether they have autoimmune disease or not. I don't. I can't say that I would say specifically it affects my lupus patients more. I'm not saying that I've done a giant study about whether or not hyperemesis affects patients with autoimmune disease more, but I wouldn't necessarily say, oh, every patient I have with lupus has hyperemesis. And as the audience probably knows, hyperemesis can affect a pregnancy and not another pregnancy. So each pregnancy is so different, and probably has to do with a bit your health state, your reaction to the hormones. We do treat hyperemesis. So, 25% of women will have some type of nausea, vomiting of pregnancy. That's not necessarily hyperemesis. Hyperemesis is where you have weight loss, derangement of your metabolic indicators, and really cannot, stay hydrated, basically. And we treat the gamut with medication, for the early stuff and diet modification, and then all the way to, inpatient hospitalization with medications. And there is some overlap because sometimes hyperemesis gets so bad that you need steroids. And steroids do seem to work in the worst cases of hyperemesis.
Differentiating lupus, central nervous system disease, and depression, psychosis, and a lot of the things you're talking about, and attributing it to lupus activity versus, let's say, an event, and that event that you're talking about might be postpartum. First of all, I think you can run blood tests that can look for things like high DNA, things like low complement, the things that you get done all the time, right, at most of your visits, and your urine. So there are factors in the blood that are somewhat specific for lupus. I don't know about your doctors, but I check the DNA and the complement on my patients all the time. And so if I see a change suddenly, that may make me concerned about central nervous system lupus, as affecting the depression. When you're postpartum, there are tests that can be done that weren't so safe to do during pregnancy. And, getting a MRI or some other things that you might not have done before, maybe we can evaluate you a little bit more closely. And sometimes two things can coexist. And sometimes you take the patient's prior history into account. Because part of what you're also asking is, if someone never had central nervous system lupus, what are the chances that they're going to get that new manifestation when they never had it before? Which also brings up, how often does pregnancy change the course of lupus? And do you develop new things which you didn't have before? Generally, the answer is no. So again, taking the person's history into account is really important in addressing this question. And of course, the treatments may be different. And I've seen both. So I think you just need to work with your rheumatologist and, maybe the psychiatrist, and you do your best to work it up.
I think everyone is affected so differently with lupus. So, I don't know what your flares look like or how often or how severe they are. So I think that, is a really big factor. I have my parents close by and siblings in the same town. So I feel like I've been able to have a lot of support, and And I think lupus or not parenthood, is hard, but everyone, everyone chooses their path and rocks their path. So I don't have the best advice for you, but I would say maybe talk to people who are better suited to answer that, who have done it with
less support, less sort of like,
Can
knowledge,
I add a little bit to this? Sorry, Veronica
Sure.
here. So I think that everybody's village looks a little different, and you can kind of craft whatever that village looks for you as you start your journey. I think we're all lupus warriors, and you're capable of doing this on your own if you choose to. Again, health considering and all of that good stuff that the doctors just talked about. But in terms of being a mom and doing it, you can craft what that looks like and what that journey looks like for you. And I firmly believe that everybody's village looks a little bit different, whether it's, support from your friends, from your family, from nannies, daycare, whatever
Sure.
it may look like and whatever that means. So I wish you all the best, and we're all here to support you.
That was lovely. Very
Yeah.
nice.
That was lovely. I think, you kind of shift your mindset, shift your support system to, instead of a partner, again, I've become such good friends with neighbors who I feel like could help me at any point, or really anyone who is supportive, which I'm sure there's a lot.
I want to thank all of our panelists for their time and their expertise this evening. I also want to give a special thanks to the LRA YLB Leadership Committee for their support and helping compile the questions this evening. And also a shout out to Andrea O'Neill and the LRA team for their continued support for this tremendous series, and for all of you for joining from all over. I know we're all scattered now across the country for the YLB. I encourage you to continue the conversation with your friends and loved ones. Please share your feedback. If you want a part 2 of this series, let us know. That's something that we're considering, but we definitely want your feedback. And everyone have a great evening.